Now proceeding our last case, which will be by the Dr. Faraz Ahmed from the CMH Lahore. He is going to talk about the retrograde approach of opening of the CTO. Dr. Faraz Ahmed.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Faraz Ahmed from Army Cardiac Center, CMH Lahore. I'm going to present a case how a retrograde approach for opening a chronic total occlusion. First of all, the case summary. 52 years male having an CCS3 class angina for the last 3 months with the comorbids of cigarette smoking. ECG showed some ST sags in the inferior leads, and echocardiogram showed good ejection fraction. Angiography revealed critical two-vessel disease, which I will show later. MPS scan was planned, which showed severe ischemia in the RCA territory, and there was moderate to severe ischemia in the LAD territory. According to the angiogram, I will show later, the CABG surgery was advised, but patient was unwilling for the surgery despite multiple visits and counseling sessions. So here are the angiogram views. Right coronary artery is totally occluded in the distal course with some late filling of the distal vessel. It's through, probably through the ipsilateral collaterals. Looks like there are microchannels, but these are the collaterals. And you can also see a critical disease in the mid-LAD. So a strategy was decided for the PCI, in which we decided to go for the anti-grade wide strategy. Used a 6 French hockey stick guide, and one can see the bridging collaterals. Okay, here you can see in this picture, the arrow shows the total occlusion, and there are ipsilateral bridging collaterals, which are appearing like microchannels. The JCTS score overall is 3. Started with anti-grade wire escalation technique. I started with the pilot 50 wire, but it could not cross. Pilot 200, although went across the lesion, but it went extra plaque. Same stand for the Gaia second when escalated. It also went extra plaque despite multiple attempts. So what's next? There were 2 options. Either we reattempt after abandoning the procedure and bringing back the patient so that the section can heal, as multiple dissections planes have been developed with the anti-grade wiring, or the other way is we go retrograde. So it was decided to go with the retrograde approach using a 7 French guide XP3. It was cut down to shorter the length to up to around 85-90 centimeter. So you can see I have used this Sion black wire with the microcatheter named as fine cross, and Sion black was used for the septal surfing. Sion black wire crossed successfully into the PDA branch after some effort. So I tried to cross the Sion black retrogradely through the plaque because generally the distal fibrous cap is tapered, and it often allows even the softer wires to cross retrogradely, but Sion black wire could not cross. So what are the options now? Either we go for retrograde wire escalation or retrograde dissection re-entry, or we keep it as a marker for the entry grade wiring. So why a retrograde approach is developed? Because of the characteristics. The proximal fibrous cap is usually thicker and harder, and the distal fibrous cap is typically tapered. So escalated to pilot 200 using the microcatheter fine cross, and the pilot 200 successfully crossed. Here you can see the pilot 200 has crossed successfully and has reached the proximal cap, and you can also note with the anti-grade injection that there are multiple dissection planes in the distal RCA. Then it was tried to advance the fine cross catheter through the plaque so that externalization process can be started, but fine cross could not be advanced, but it reached the proximal cap at least. As the fine cross has reached the proximal cap, so the Pilot 200 was replaced with the RG3 wire, and RG3 wire was successfully entered into the guide catheter, as you can see in the second screen. So still, as externalization is further to be done, so we needed to advance the microcatheter, and to advance the microcatheter, some maneuvers were needed. So to deliver the microcatheter, it was decided to increase the support, which was done by trapping the RG3 wire in the guide catheter with the 2O balloon, and by trapping the wire, the microcatheter was advanced. After advancing the microcatheter, the wire was externalized, and retrograde check injection was given to see any damage to the collateral branches. So then switched to antegrade technique, antegrade approach, and dilated the distal RCA lesion with 2O15, and Sion wire replaces the RG3 wire. Deployed 3O48 DES in the from PDA to distal RCA, and 3548 DES from proximal to distal RCA. Post dilated with 3.515 NC balloon, and here was the final result. Surprisingly, the RCA came out to be a huge vessel, spraying a very large territory of the inferior and posterior segments of the heart. Here you can see a very large territory supplied. LED also fixed in the same attempt, deploying a 3538 DES from proximal to mid course, and it showed a good result. Here are the results of the RCA and LED. So the take-home message is the retrograde approach through collateral channel for CTOs can improve the success rate, especially in cases of difficult antegrade approach or in case of previous antegrade failure. In case collateral channel is dissected, ruptured, perforated, it is advisable to stop the procedure, stabilize the patient, schedule the patient for another attempt, or reconsider surgery. Moreover, before starting the procedure, the total amount of the contrast agent to be injected should be calculated. Although the retrograde approach is conceptually simple, it requires very skilled operators and a long learning curve. Thank you very much.
Thank you, Dr. Faraz. It's a very, very nice case done by you.
It was a good case, good result. One comment. Have you tried the antegrade escalation with the balloon, with the fine cross? You have started after trying 1-2 wires.
Sir,
where you ultimately go into the retrograde.
the Gaia wire was attempted with the fine cross, but Pilot 200 wire was attempted without taking the microcatheter. But to track down the Gaia wire up to the plaque, the microcatheter was used to replace the Pilot 200 with the Gaia wire. But somehow that is just to replace the wire, because microcatheter usually does not add much to the features of the wire. Wire makes its way by its own. When we attempted, if we had chosen a right wire, it has the features of its own, but Gaia wire could not cross.
Have you done any subjective test for LADs?
Yes.
Any ischemia?
MPI scan was done, which showed severe ischemia in RCA territory and moderate to severe ischemia in LAD territory.
Okay.
Sir, one question.
Your antegrade wire crossed the lesion, and how did you figure out that this is extra plaque, not intraplaque, it's not intraluminal?
Obviously, I have shown only one clip for both Pilot 200 and Gaia 3, If I am supposed to show the whole case, it can easily be seen because there were other wire placements as well for the Gaia where it was very clear that it is going extra plaque.
There, your microcatheter might have helped you to figure out whether this is intraplaque or extraplaque or is it.
Yes, microcatheter. You mean we take a check with the microcatheter to see where is the wire?
Yes.
Yes, but I didn't do it because the Pilot 200 already has developed many planes. So I thought it will make further worse, and Gaia wire is a penetrating wire. So there should be less dissection, and let's try with the Gaia wire if it goes antegrately.
And what was the rationale to fix the LED after the RCA, not before RCA?
Yes, okay, you are right. When I tried to cross the Sion black through the septals, and it was in my mind that I may need to fix the LED before the RCA as I'm going retrograde now. When I crossed the Sion black followed by the microcatheter, I looked at my patient, looked at the ECG, the pressures all remained stable. The patient tolerated it well. So rather than fixing the LED and losing the collaterals or harming the LED before attempting for the RCA, it was relatively illogical for me to go for an easier target first and coming back to the harder target afterwards. So I decided as the patient is tolerating, I should go for the RCA.
It's always good to have a protection wire in the donor vessel because if anything goes wrong there, then you should have a wire in that vessel. A protection wire.
Yes, you're right.
One question regarding, for example, you are short of some equipments like long length microcatheter that's not available to you or that's short, and you have difficulty for externalization of wire into the antegrade catheter. So is there any other options to get the wire antegradely, which you took the wire from retrograde approach? Did you understand my question or not?
There are two shortcomings of retrograde, which I understand now. One is the guide length. Usually we have a 100 centimeter guide. The other is the microcatheter, which is up to 150 centimeter longest available. So it is often a phenomena while going retrogradely that microcatheter could not be advanced into the antegrade guide. This is what you are asking, what else I can do in the presence of these shortcomings.
Yeah.
The other ways are obviously we can snare the wire or like increase the support, we change the microcatheter, or we change the septal, maybe a shorter septal course, which can allow the microcatheter track up to the antegrade guide.
But yeah, with
But changing a microcatheter, you know, it will cost you a lot.
Yeah.
And financial constraints are always a problem, especially when we are doing a case which is retrograde, already costing a lot.
The cost-effective way is to snare the wire and with antegrade guide
Exactly.
catheter.
Snare is obviously an option. As my catheter was up to the proximal to mid RCA, so I thought if I trap the RG3 wire, I can easily pull it into the other end.
Sir, snaring the retrograde wire or snaring the antegrade wire?
No,
Wait.
the retrograde RG3 wire, so that we can externalize it.
Okay, there is another technique called reverse wire tripping technique.
Sorry.
Here. Reverse wire tripping technique in which you can take a micro snare through reverse this retrograde channel, and you basically snare the antegrade wire and you pull it into the this artery. Reverse wire tripping technique. This is
Okay.
Did you use tip in technique in here?
I did?
Tip in.
No.
Which one then? Rendezvous? Or you just snared it? Probably
No.
missed it.
I trapped the wire, and by trapping I pulled up the
Tripping
wire.
wire for support?
Yes,
For support or just to pull it?
just support.
I think one simple question.
Sir.
If you were not successful with your RCA, would you still stent your LED?
No, sir. I would have then sent the patient to the surgery.
Very smart, very
Sir.
smart. Thank you.
Thank you.
Thank you very much, Dr. Faraz. and it was the last case of the session. So thank you very much all the speakers, thank you very much all the chairpersons, and the valuable comments. Now we'll proceed for the another session. Will be moderated by Dr. Mohammad Hashim Kalwar. So I'll hand over to Mike, Dr. Hashim Kalwar. Please come on the stage.